good discussion around frontline therapy. Now, there still are going to be a healthy number of patients, despite our goal of complete responses, who need second-line treatments. And Neeraj, I was really impressed during our Twitter chat regarding how you sort of developed this construct around how you approach second-line treatment with frontline regimens like nivo/ipi and axitinib and so forth.
So I think patients have different goals. When they are seeing us for the first time, they want to live longer, live better, complete responses probably take the priority over everything else. But by the time we are seeing patients in second-line therapy and third-line therapy setting, I think more reality has set in. I think still patients want to live longer, but we know that complete responses still can happen, but may not happen, are much less likely to happen. So I think when we are looking at patients who are starting second-line therapy, how they have among all the drugs we have, and how these drugs are able to induce responses and progression-free survival benefit. So in my view, the overall survival and complete responses, which were the most dominating talking points between me and my patients, by second-line and third-line, I'm looking at response rates and progression-free survival. So that's a shift what is happening in my clinic when I'm talking to these patients. So I'm looking at progression-free survival benefit and primary progressive disease rates, which is just opposite of complete responses. So what is the likelihood of a agent be associated with high primary progressive disease rates as the best response? Because as we know, these patients are likely not going to see the subsequent line of therapy if they have progressive disease in the second line. So keeping those in mind, I look at agents who are really good from the perspective of progression-free survival benefit and are least likely to result in high primary progressive disease rates. So there are 4 choices right now: nivolumab, cabozantinib, axitinib, and lenvatinib everolimus combination. So I tend to put lenvatinib everolimus combination on the side for now, because that is a 2-agent combination, more toxic, more expensive, and we should just talk about axitinib, nivolumab, and cabozantinib. I think among these 3 drugs, cabozantinib seems to be most attractive to me because the primary progressive disease rates were only 12%, as opposed to, say, 35% with nivolumab, or relatively much higher number. And still, progression-free survival is the best as a monotherapy in salvage line therapy setting.
I think my sentiments echo yours. Progressive disease rates, response rates, those are all so key when you're looking at second-line therapy, and it certainly is a different juxtaposition versus first-line therapy. And I tend to use cabo. Any differing thoughts there?
No, I agree. We tend to use cabozantinib. I think, and as we move forward, and we start having VEGF IO combinations or IO alone, the question is like, where's the data after that? When you have VEGF and IO, are you progressing on the IO, or you progressing on the VEGF? And so we've actually looked at that retrospectively with cabozantinib in sort of the post-IO setting. So close to 100 patients were looked at retrospectively, and response rates were 27%. Well over 25% in these patients who have progressed on IO. So independent of IO therapy, cabozantinib is certainly an active agent in the second line.
Yeah, absolutely. I just worry, as we're adopting more of these VEGF immunotherapy combinations in that frontline setting, what they're resistant to, as you say, Brad, when they're progressing, and what we should be sequencing. But we do know that, the VEGF inhibitors tend to have activity, even after other VEGF inhibitors. So cabozantinib certainly has activity after sunitinib, pazopanib regimens. Axitinib, we have great data for in the second line setting as well. So, really thinking about the right patient and, the tolerabilities of the agents, I think it's a quality of life issue also, right? In the second line setting, we're talking about patients who have been on multiple lines of treatment. They're a little bit more frail. We want to get them to live longer, but also maintain their quality of life while living longer.
That makes sense. And just on a related note, I just wonder if there are any patients nowadays who you might ever consider re-challenging with the same agent. I remember at one of the first ASCO GUs I ever went to, Brian Rini presented data related to what I'll call a sunitinib sandwich, right? So patients start on sunitinib frontline, they get a handful of therapies thereafter, and really for lack of available agents, they went back to it. These days, can you foresee that happening?
Yeah, I mean, there's so many great lines of treatment now, and that's the beauty of having multiple lines of treatment for our patients, is that there are so many ways we can sequence, and I don't foresee re-challenge with an agent, and that's why, you know, in patients who are on a therapy, I tell my patients that we really need to optimize the time on an agent and manage their toxicities, or, you know, if there's a tiny bit of progression, let's watch it a little bit more and try to optimize this length of time that we have on each regimen. Because once we're going, you know, go on to a different regimen, I'm not going to circle back to the original one, right? And try to figure out who should be getting what treatments in the next line.
One situation I can think of is you treated somebody with ipilimumab, nivolumab combination, patient achieved complete response or partial response, you stopped the therapy, and after 1 year they have rapid disease progression, so they required a TKI. Yeah. But after that, once TKI fails them, after that I think it's reasonable to go back to the ipi-nivo combination or nivolumab like monotherapy.
Yeah, because you've seen that disease activity early on, right?
And they had not progressed on those immune checkpoint inhibitors early on, so there may be a room to use them.
That's right.
But beyond that, I don't think there's a space for re-challenge.
That makes perfect sense to me. You know, Brad, I'm going to ask you about a situation that comes up. I'm sure it comes up in your practices as well. You get a referral from the community for a patient, for instance, who failed on nivolumab and then got switched over to atezolizumab, for instance, with the rationale being you go from PD-1 to PD-L1. Any credibility to that approach?
I think right now the data suggests that probably it's not an effective approach, and we did a look at several patients who switched from one IO therapy to another, and none of those patients responded in respective review. I mean, that's being looked at in ongoing clinical trials where not just maybe switching from one to the other, but switching to nivolumab and maybe adding another agent to try to sort of tweak that immune response. The idea of not just switching, but doing something more than switching. I think there's certainly an appeal in that approach, but I think just switching from nivolumab to atezolizumab doesn't, probably at this point we don't have data, it's just that that's going to be efficacious for our patients.
I think if a patient's really interested in more immunotherapy at that point, I'd much rather do a combination, you know, novel immunotherapy combination or something else where, you know, we're adding to that PD-1 effect, and that's probably easiest done on clinical trials.
Yeah, I think that's an important message. Going from PD-1 to PD-L1 at this point in time doesn't really seem to make a lot of sense.